Welcome back to the deep dive. Today we are undertaking a really critical mission, cracking open the science of drug response. Why is it that the very same medicine can be a perfect cure for one person and for another cause serious side effects or maybe not even work at all?
It's the question that sits at the very core of clinical practice, and the answer really is rooted in pharmacokinetics, or PK for
Yeah.
short. Our sources gave us this incredible blueprint of what the body does to the drug, that whole process of ADME.
ADME. I love that mnemonic. Absorption, distribution, metabolism, and elimination. It's so clear, and this knowledge is just vital, whether you're talking about an aspirin or a powerful anesthetic.
Absolutely. PK dictates everything.
So for this deep dive, the source material you found covers the whole spectrum, right? From basic chemistry to, what, pharmacogenomics?
The full range. The mission is to zoom in on the key variables, things like molecular size, local pH, and most importantly, our own individual genetic differences that determine your unique reaction to any medication.
And no matter how you take it, a pill, an IV, it's all a race against time, isn't it? Trying to get that tiny, unbound, active piece of the drug to the right receptor before the body can, destroy it.
That is the ultimate chemical challenge.
So let's start at the very beginning. Absorption. Getting the drug in. What does a molecule need to successfully cross the body's barriers?
Well, a drug's intrinsic properties are paramount. And the first rule is that size matters a lot.
Okay.
To easily slip through those cell membranes, molecules generally need to be quite small. We're talking molecular weight under about 100, maybe 200 Daltons. Anything bigger is going to need some help.
And what kind of help are we talking about? How does the body move these things across membranes?
We basically put transport into two buckets. First, you've got passive transport.
Simple diffusion.
Simple diffusion. The drug just follows the concentration gradient, high to low. It's like rolling a ball downhill. No energy needed.
And the other side of that coin?
That's active transport. This is much faster, and it requires energy, ATP. And the amazing thing here is it can actually move drugs against the concentration gradient.
So uphill.
Exactly. It uses these specialized carrier proteins that act like bouncers at a club,
Yeah.
especially in places like the gut lining or the blood-brain barrier.
So once a drug is small enough, the next big hurdle seems to be this delicate balance between being water-soluble and fat-soluble.
This is really where the chemistry gets cool. The vast majority of drugs are weak acids or weak bases. So they exist in two forms at the same time: a charged, ionized form that loves water, and an uncharged, non-ionized form that's lipid-soluble.
And to cross a fatty cell membrane, I'm guessing you need to be the lipid-soluble one.
Only the non-ionized, uncharged form is lipophilic enough to do it. If the drug is stuck in its charged, water-soluble state, it's stuck. It can't cross.
What determines that ratio then? Charged versus uncharged?
It all comes down to the drug's own dissociation constant. Its pKa relative to the pH of the fluid it's in. If the pH of the environment is close to the drug's pKa, that balance is on a nice edge. Even a tiny change in acidity can totally shift how much of the drug gets across.
I saw a concept in the sources that sounds like something from a spy movie, ion trapping, where a drug gets across a membrane only to be chemically locked on the other side. How does that work?
It's exactly what it sounds like. A drug moves from one fluid compartment into another with a very different pH. Once it's in that new environment, it grabs or loses a proton, its charge changes, and suddenly it's super ionized and can't get back out. It's trapped.
Can you give us a concrete example of that?
Sure. Take morphine sulfate. It's a base with a pK of $7.09. When you swallow it, it immediately hits the stomach, which can have a pH as low as, say, 1.9.
Whoa, that's a massive difference.
It is. In that super acidic stomach, the basic morphine just gobbles up protons, becomes highly ionized, and gets trapped there. It can't easily cross the GI membranes until it moves into the more neutral small intestine.
So the acid actually protects you from a rapid overdose in a way, but slows down the drug's effects.
Precisely. And the sources highlight two really serious clinical sides to this. First is maternal-fetal transfer. Fetal blood is a bit more acidic than the mother's.
Oh, I see where this is going.
Basic drugs cross the placenta, enter the more acidic fetus, become ionized, and get trapped. They can accumulate.
That's concerning. What was the other example? Something with anesthesia?
Local anesthetics, they're also weak bases.
Yeah.
If a patient gets an overdose and their breathing fails, they develop respiratory acidosis. Their blood gets acidic.
Okay.
That acidic blood then traps the basic anesthetic agent in the brain, concentrating it right where you don't want it, and making the CNS toxicity much, much worse.
So the body's chemistry turns against itself. Now, once a drug is absorbed, we have to get it to the rest of the body. We know IV is 100% bioavailability, but why is oral so variable, sometimes as low as 5%?
That huge drop is almost always because of the first pass hepatic
The
effect.
liver, right.
The liver. When a drug is absorbed from your gut, it doesn't go straight into your main circulation. It goes through the portal vein directly to the liver first. And the liver, being our main processing plant, gets the first crack at metabolizing it before it ever sees the rest of the body.
So it's like a customs checkpoint that destroys half the cargo.
A huge amount of it, yeah.
Hmm.
That's why you have to take a much higher dose orally. It's also why a drug like nitroglycerin for chest pain is given under the tongue
To bypass the liver.
to bypass the portal system and that first pass effect entirely. You get rapid, direct delivery.
Okay, so once the drug survives that and gets into the bloodstream, we hit distribution. And the first thing it runs into is protein binding. How does that work?
A lot of highly lipid-soluble drugs like warfarin or propofol, they bind very tightly to plasma proteins, especially albumin.
Yep.
When they're bound, that drug-protein complex is just too big to leave the blood vessels. It effectively traps the drug in the circulatory system. Only the tiny unbound or free fraction is actually active.
Some of these drugs are like 98% bound. It sounds like a disaster waiting to happen if another drug comes along and bumps even 2% of that off, suddenly doubling the free drug.
It sounds incredibly dangerous, and theoretically it is. It was a huge concern in pharmacology for years. But the sources are pretty clear that in a living person, an open system, this rarely causes clinical toxicity.
Why not?
Because our elimination systems, the liver and kidneys, are just so efficient. That sudden spike in free drug is usually cleared so fast that the high concentration doesn't last long enough to cause a problem.
Interesting.
The real danger is if the displacing drug also inhibits the enzymes that clear the first drug, then you got a problem.
That's a great distinction. Now, to even think about where drugs go, the sources talk about these theoretical spaces called compartment models.
Right, because we can't map every cell. So we simplify things with a two-compartment model. You have the central compartment. This is the vessel-rich group.
Yeah.
Heart, brain, liver, kidneys.
All the high traffic areas.
Exactly. It's only about 10% of your body mass, but it gets 75% of your blood flow. Then you have the peripheral compartment, muscle, fat, bone. The other 90%. Drugs go to the central compartment first, then slowly spread out to the periphery.
Which brings us to volume of distribution, or V dollars. It's not a real volume, but it's crucial for dosing. What does a large V dollar actually tell us?
V dollars is a conceptual volume. It tells you how widely a drug is spread out. If a drug has a large V dollar, it means it didn't stay in the blood. It rushed out into the body tissues. It's a dead giveaway that the drug is highly lipid soluble.
And this is where we have that aha moment with propofol. It's super lipid soluble, has a huge V doll. A patient gets a dose, they fall asleep, and then they wake up incredibly fast just minutes later. Why? If it's elimination, half-life is actually quite long.
This is the perfect example of distribution versus elimination. That rapid wake-up has nothing to do with the drug being eliminated from the body.
So where did it go?
It's all about redistribution. The drug concentration in the brain plummets because it's rushing out to fill up those huge peripheral compartments, like fat and muscle. They soak it up like a sponge.
So the patient wakes up just because the brain concentration dropped below a certain level.
That's it. They wake up, they're talking to you, but the vast majority of that drug is still in their body, sitting in their fat tissue.
So they're awake, but not clear.
Not at all. Propofol has a long elimination half-life, maybe 11 hours. So even though they feel alert, they're still groggy, their coordination is off, and they absolutely should not be driving. That distinction is clinically huge.
What a powerful concept. Okay, let's move to the final stage, clearing the system. Metabolism and elimination. What's the fundamental goal here?
The goal is transformation. The body needs to take these lipid-soluble drugs and convert them into water-soluble metabolites so the kidneys can flush them out. And that job mostly falls to the liver.
And this happens in two stages, phase 1 and phase 2.
Right. Phase I reactions, things like oxidation or hydrolysis, they usually make the molecule a little more polar, a little more water-friendly.
Okay.
And phase 2 is conjugation. The body takes that phase I metabolite and sticks a big water-soluble group onto it, like glucuronic acid. That almost always creates an inactive compound that's super easy for the kidneys to excrete.
And the engine driving most of phase I is the famous cytochrome P450 system. The CYP enzymes. Why are they so critical?
Because they metabolize the vast majority of drugs we use, and importantly, their activity can be changed. And that's what drives most of the major drug interactions we worry about.
So let's talk about those. First, enzyme induction.
Induction means that certain things like chronic alcohol use or some seizure meds can ramp up the activity of these P450 enzymes.
Okay, so you become a super metabolizer.
In a way, yes. You clear drugs faster, which might mean you need higher doses for a drug to be effective.
And the opposite, enzyme inhibition, is where the danger often lies.
Inhibition is when a drug like cimetidine or the antibiotic erythromycin decreases enzyme activity. If you inhibit the system, drugs aren't cleared. They build up and you can get severe toxicity. Understanding these interactions is just fundamental to safe prescribing.
When we talk about elimination, thankfully, most drugs follow what's called first-order kinetics.
They do. First order just means the body clears a constant fraction or percentage of the drug over time. This gives the drug a predictable, steady half-life.
But then there are the exceptions, the ones that follow zero-order kinetics.
Zero order happens when the enzyme system gets saturated. It's working at max capacity. So it can only clear a constant amount of drug per unit of time, no matter how much is there. The classic example is alcohol at high doses. The half-life is no longer constant.
So we've mentioned half-life, but the sources introduce a more advanced idea for infusion drugs, context-sensitive half-time, or CSHT. Why is the standard half-life not good enough here?
Because of those compartments we talked about, if you give a drug for just a few minutes, it mostly stays in the central compartment. But if you run an infusion for hours,
It accumulates in the fat and muscle.
exactly, it saturates those peripheral compartments. So when you turn the infusion off, the drug that's stored in the fat starts flowing back into the blood, propping up the concentration. The CSHT is the time for the concentration to fall by half after you stop, and it depends entirely on the duration, the context of the infusion.
So it's the real-world half-life for recovery, a much more accurate predictor of when a patient will actually wake up.
It connects the PK model directly to the clinical reality. It's an incredibly useful concept.
One last PK detail, clearance. It depends on blood flow and the liver's extraction ratio. What does this mean for patients with liver problems?
It splits drugs into two categories. First, you have perfusion-dependent drugs, high clearance drugs, like lidocaine. The liver is so good at grabbing them that their elimination depends almost entirely on how much blood flow the liver gets.
So in a patient in shock with poor blood flow, lidocaine could become toxic.
Very quickly. The other category is capacity-dependent, low-clearance drugs, like diazepam. Here, blood flow doesn't matter as much. What matters is the health of the liver's enzymes. So in a patient with cirrhosis, their ability to clear diazepam would be severely impaired.
Okay, we've covered the physics and chemistry. Now for the biggest variable, the individual. Before genetics, what other patient factors force us to adjust these PK models?
Oh, age is a huge one. Neonates and the elderly have reduced liver and kidney function. Things are just slower. And in the elderly, they have more body fat, so lipid-soluble drugs can accumulate and stick around longer.
The sources even point to gender differences.
Yeah, it's a growing area of research. For instance, some studies show female patients are more sensitive to certain muscle relaxants, while male patients might be more sensitive to propofol, sometimes needing a lower dose. There's likely a hormonal influence there.
This all leads us perfectly into pharmacogenomics. The idea that the PK rulebook isn't universal, it's unique to our own genetic code.
That's the whole field in a nutshell. It aims to get us away from the one-size-fits-all model. It looks at tiny variations in our genome called SNPs to predict how you, as an individual, will respond to a drug. Will you clear it fast, slow, or not at all?
And the most clinically important example of this seems to come right back to that P450 system, specifically the CYP2D6 enzyme.
The genetic variability in CYP2D6 is just staggering. People can be ultra-rapid metabolizers, extensive, intermediate, or poor metabolizers. And the distribution is wildly different across ethnic groups. Some populations have almost 30% ultra-rapid metabolizers.
And this has had tragic real-world consequences, especially with a very common drug, codeine.
Codeine is the classic prodrug. It's actually inactive. Your body has to use CYP2D6 to convert it into its active form, which is morphine.
I see the problem.
Ultra-rapid metabolizers. They have this hyperactive CYP2D6 enzyme, so they convert codeine to morphine way too fast, creating toxic, sometimes lethal levels of morphine from a normal dose.
And the sources noted this risk was highest in two very specific groups.
Yes. In children after tonsillectomies and in nursing infants whose mothers were ultra-rapid metabolizers. This specific high-stakes risk led the FDA to issue a contraindication for codeine in these groups. It's a powerful argument for doing genetic testing before prescribing.
So to pull this all together for the listener, we've seen how the body's chemistry can trap drugs, how redistribution makes you wake up fast while the drug is still there, and why we need things like CSHT to predict recovery.
Pharmacokinetics gives us the rulebook for how drugs move. But what pharmacogenomics reveals is that every single person has a unique, genetically printed edition of that rulebook. The drug's journey is always a personal one.
Which leaves us with this thought. Since we already have genetic tests that can predict failure or toxicity with common drugs like codeine, and genetic profiling is only getting cheaper, how soon will it be until your entire medical profile, every prescription, is dictated not by a standard chart, but by a pre-screening genetic chip, fundamentally changing the very concept of a standard dose forever? Something to think about.